I think actually we need to hand over to Anna Kramvis to conclude. So thank you so much to all the panel from Fabienne. And Anna, are you there to wrap up?
Okay, thank you very much, Marla. Thank you for leading the discussion together with Fabian. The incoming chair of ICE-HBV, Fabian Zulim, Peter Revel, and I would like to thank the participants, panelists, speakers, and chairs for their contributions. The participants for attending and for the insightful questions, the panelists for their rich conversations and vibrant discussions, the speakers for their well-prepared and erudite presentations, and the chairs who together with Capuchin managed the time so effectively. Thank you very much. When we organized the workshop, we set out to answer the following questions. Why do we need biomarkers? What biomarkers are available? How do they perform? And to recognize the gaps and challenges and to chart a way forward. In the first session, chaired by Ulrika Protzer and Timothy Block, Barbara Testoni gave an excellent overview of both the classical and the novel biomarkers and concluded that not one biomarker fits all and that we need an integrative assay. In her presentation, Kyung-Mi Chang effectively summarized the spectrum of immunological serum markers that are clinically relevant in following the clinical manifestations of HBV and for monitoring therapy. She concluded that though there are many immune biomarkers have been examined, none to date appear to be superior to other clinical and virological measures. Thus, we need further studies. Florial van Bommel clearly demonstrated that RNA has the potential to be a marker for chronic HBV infection and response to therapy, especially capsid inhibitors. RNA containing virions are independent of HBV DNA synthesis and reflect transcription of pgRNA from cccDNA, and therefore can be used as a surrogate marker for cccDNA. However, to date, it's not clear whether it is superior to currently available biomarkers, and one cannot distinguish between an RNA derived from episomal and integrated DNA. In his presentation, Jiaming Hu showed us that the HB core-related antigen assay measures 3 different proteins: HBC antigen, HBE antigen, and the pre-core protein. He shared with us his group's elegant experiment showing that kinetics of each of the 3 HB core-related antigen components in HBV-infected chimpanzees and analogous WHB antigens in woodchucks infected with WHB could be used to follow natural infection and response to antiviral treatments. However, further studies are necessary to determine the correlation between HB core-related antigen with classical markers, including HBS antigen and HBV DNA. Harry Janssen compared the utility of classic and emerging biomarkers in following natural history and treatment response. He demonstrated that the different phases of disease, the HBV genotypes and mutants, and treatment modalities can affect the sensitivity of the different biomarkers. He concluded that HBV DNA, quantitative HBS antigen, and HBE antigen will remain the mainstay because they have been well validated, whereas HBV RNA and HBV core-related antigens still needs validation, and the sensitivity of those assays need to be improved. As new drugs become available, additional biomarkers will be required. These concerns were explored further in the first panel discussion led by Adam Goering and Veronica Miller. From the discussion, it became clear that the biomarkers required for HBV cure are dependent on the drug activity, the cure endpoints, their predictive value, and their sensitivity. As we know, the current therapies do not target cccDNA. However, as we proceed towards a cure, cccDNA remains the ultimate target, and as we heard today from Maura Dandry's presentation, we will require non-invasive biomarkers that can act as surrogates for cccDNA. It is important to be aware that distinct therapeutic approaches may affect levels of virological markers. In vivo models, such as the liver humanized mice, will be useful in determining confounding factors. In her presentation, Teresa Pollicina showed us that we need biomarkers with increased sensitivity to detect OBI. Although there are improvements with the development of droplet digital PCR and more sensitive HBs antigen assays, there's still much work to be done so that OBI is not missed. Because serum HBV is usually present in low concentrations and may only be intermittently detected in OBI, analyzing serially collected blood sample is recommended for OBI diagnosis. Anti-HBC may be used as a surrogate marker. Patricia Fauci gave us the definition of cancer biomarkers for the early detection of HCC and showed that different approaches such as combining AFP, AFP-L3 and ultrasound or the Gallup model and longitudinal measurements can increase sensitivity. She informed us about the components of the liquid biopsy as a new development. Daryl Lau clearly demonstrated that the algorithm for treatment proposed by the WHO may be cumbersome and we may miss a number of patients, especially in low middle income countries, by using only APRI and HB antigen. Point of care tests are very important as we bring technology to the patient. She highlighted that there are a limited number of rapid diagnostic tests that are available and we need more development. Genotypes can affect the sensitivities of the different RDTs, as can ART in HBV, HIV co-infected patients. There is no validation for using DBS in rapid diagnostic test. Dieter Kleber gave an excellent overview of the gaps and challenges and why we need biomarkers. He proposed that new useful biomarkers may be messenger RNA, MHBS and LHBS, and recommended new biomarkers be tested using genotype panels as well as in vitro systems. It is evident for today's panel discussion led by Marla Maini and Fabian Zulim that there are many opportunities and challenges. Relative to virological markers, immunological markers are more complicated and need further development. We do not have an immunological marker for functional cure or one that reflects what is happening in the liver. We need to integrate and to confirm. Fine needle aspirates appear to be promising but require validation as in longitudinal follow-up. Capacity development is required in clinical trial sites and there are operational challenges that have to be addressed. There are available genotype panels that can be utilized. Large collaborative studies that are representative and include resource-limited settings are necessary in order to develop a composite score that can take a number of biomarkers into account. This virtual workshop is not an end, but a way forward. It has generated, as we have seen, a considerable momentum on which we should capitalize. The ICE-HBV will provide the leadership to coordinate the synergy required by all the stakeholders. We hope by the end of the year to have the first draft of a manuscript, which together with a consensus statement will be published in 2021. We must remember at all times to humanize the voices of those affected with HBV and its clinical consequences. Please continue the good work and stay safe. Good morning, good afternoon, good evening, good night, wherever you may be. Thank you.
Thank you. Bye-bye. Thank you.
Thank you. Bye-bye.
Thanks, everybody. It was wonderful.
Bye-bye. Thank you.
Bye-bye. Thank you. Great job.
Bye-bye. Thank you all.